I think that we had a very interesting afternoon today with the abemaciclib data from MONARCH being presented that showed an improved progression-free survival over fulvestrant alone with the addition of abemaciclib. And what we noted was consistent with the palbociclib data, the ribociclib data. What was very interesting today is that there was a analysis on a phase 2 trial that looked to say, does adding a CDK4/6 inhibitor to an aromatase inhibitor improve overall survival? And interestingly, that trial, probably because it was underpowered, was a negative trial. So we know that all 3 of the CDK4/6 inhibitors that have reported out results improve progression-free survival, and we know that the toxicities can be managed. And we on all 3 are going on to be translated in the early breast cancer setting to say, will they improve outcomes? We don't yet know whether endocrine agent with the CDK4/6 inhibitor needs to be combined in every patient. But I think the abemaciclib data were very exciting, and they did cause the same side effects that we're seeing with ribociclib and the palbociclib in terms of bone marrow suppression. There was some GI toxicity with the trial that was unexpected, that they reduced the dose, and then people tolerated the abemaciclib much better. So, obviously we're waiting for confirmatory studies about the overall survival benefit because we don't have that with any of these 3 agents. And the other interesting point today that came up in the discussions was, can we use a CDK4/6 inhibitor alone? And tomorrow Sarah Toloni is going to present about CNS data with these agents. But what we found was that the combination data seems to be more effective, even if it's the aromatase inhibitor and the aromatase inhibitor and the CDK4/6 inhibitor versus just the CDK4/6 inhibitor alone. But the take-home point today from the MONARCH trial for me was that we have 3 very good agents that significantly improve progression-free survival: ribociclib, abemaciclib, and palbociclib. We just don't yet have predictive biomarkers on who benefits from which agent and which patient benefits from dual targeted agents.